Hello everyone, welcome back to my channel. Today's topic is incontinence of urine, again from medical surgical nursing. We will learn about what are the features of incontinence of urine, types of incontinence of urine, and how to manage. Let's start with the video. Urinary incontinence is a condition in which there is involuntary passage of urine. There are many functions of the body which are voluntary and many other functions which are involuntary. Passage of urine is normally voluntary. We voluntarily go to the washroom to pass out urine. Passage of stool is also voluntary. But sometimes, due to dysfunction of the muscles around the bladder, what happens is there is involuntary passage of urine. How it happens, we will learn in the body of the topic. For introduction, there is irregularity in urine output in patients who are having urinary incontinence, and also urine passes out of the body when patient is unaware of it. It is generally more prevalent in menopausal women because during menopause there is lack of estrogen hormone in the body, and because of lack of estrogen many of the muscles of body becomes unable to function like adult, like the previous age. So it is seen mostly in menopausal women. It is anatomy of both male and female pelvis. These are the organs: bowel, bladder, rectum, spine, pelvic floor muscles, urethra, urinary bladder. This diagram is shown because we need to know what organs are present in the pelvis, what are the muscles that are present in the pelvis, and disruption in one of the organ might disturb another organ as well, another surrounding organ as well. So here is muscles of the pelvic floor. Inside the pelvis bone, there are many kind of muscles: piriformis, coccygeus, pubococcygeus, iliococcygeus, rectalis, and the muscles which surround the urethra, urinary bladder, are our main concern in this topic. Pelvic floor muscle, they work together. They cover the organ, support the organ, and help the organ in movement. It is the movement of muscles that helps to carry function of the internal organ. When a pelvic floor muscle contract, what happens at the bladder and urethra is when the pelvic floor muscle contracts, urethra, anus, and vaginal opening closes. So this contraction is necessary to prevent involuntary passage of urine. Incidence and prevalence of stress urinary incontinence. Approximately 13 million people in the US suffer from urinary incontinence, and around the world 400 million. Among sufferers, most of them are women because menopause is a natural phase that occurs in every woman, and urinary incontinence is one of the symptoms of menopause. So there are chances that women will be more sufferer. Here are types of incontinence. We have acute incontinence and chronic incontinence. Acute and chronic we have learned in previous topic also. Acute symptom or anything which is acute lasts for less than 6 months. Anything which is chronic lasts for more than 6 months. Acute incontinence can occur suddenly due to a disease condition or due to any infection, whereas chronic incontinence develops gradually, step by step, because of some illness or some infection or anything else. We have types of chronic incontinence, that is stress urinary incontinence, urgency urinary incontinence. We also have mixed type. Let's start from stress urinary incontinence. This is related to stress. When there is any kind of stress to the pelvic floor muscles, that causes stress urinary incontinence. This pressure to the pelvic floor muscle occurs while coughing, laughing, and sneezing. This is commonly seen in older adults, old age group. Now, urgency urinary incontinence. Urgency urinary incontinence does not have any specific age group. This can occur in any age group, starting from children till the old age. Here what happens is in urgency, when someone is not able to pass urine on time, when the urge occurs. At that time, urgency urinary incontinence occurs. It is commonly seen in person who are suffering from infection and person who are suffering from neurological illness. There is a diagram for stress urinary incontinence when there is heavy weightlifting, coughing, laughing, or involvement in any kind of physical sports. At that time, stress urinary incontinence might occur. Whereas urgency, when any person is not able to visit the washroom on time, urgency urinary incontinence occurs. We have mixed incontinence, which has features of both stress and urgency urinary incontinence. This can occur involuntarily also while during pressurizing the pelvic floor muscle, like during coughing or sneezing. What actually happens in mixed incontinence is there is increase in the intra-abdominal pressure towards inside, and there is detrusor muscle contraction. Detrusor muscle is one of the muscle of pelvis. There is detrusor muscle contraction, because of which urinary system organs get compressed and urine comes out involuntarily from the body. If this is bladder, this is the urethra. Due to increase in intra-abdominal pressure within intra-abdominal organs, intra-abdominal, and due to uninhibited, unstopped detrusor contraction, urinary incontinence occurs. Mixed urinary incontinence occurs. Clinical features are patient intakes limited amount of fluid that might lead to constipation. Because of the fear of passing the urine involuntarily, patient wants to take only limited amount of fluid, which might take the patient to constipation. Patient also has disturbed sleeping patterns because anytime during night, during day, patient has frequent visit to the bathroom. That's why there are disturbed sleep patterns. There is frequency of urination. Of course, there is a frequency, knowingly, unknowingly, there is frequency of urination. Patient feels sudden rise in temperature because of whatever condition the body is facing. There is sudden rise in the temperature. The rise in temperature is a defense mechanism of the body to protect the body from whatever condition is taking to the urinary incontinence. Other associated symptoms are insecurity, feeling of insecurity, feeling anger, guilt, shame, embarrassment, socially isolated. These all are psychological symptoms that patient might have while having urinary incontinence. Diagnostic tests that we can perform for urinary incontinence is, first of all, obtaining a clinical history. Clinical history must contain chief complaint and today's health condition, present health condition. Next is a physical examination. Physical examination of pelvic floor is necessary because there might be abnormal mass, benign or malignant, or any kind of abnormal mass growing in the pelvic floor, which might be a reason of that urinary incontinence. So physical examination is one of the most necessary things. Next is menopausal history. As menopause is major risk factor, menopausal history should be taken, age of the patient and symptoms should be found. USG of pelvis gives us overall view of the pelvic organs and pelvic muscles. MRI of pelvis, again 360-degree view of all pelvic organs along with the muscles can be obtained from MRI. Stress test can be performed. Stress test can be performed in standing position. We ask the patient to stand. While standing, we ask the patient to keep two legs slightly apart. Keeping the two legs apart makes two labia apart from each other. And then we ask the patient to cough. While coughing, if the urine escapes, the patient is having urinary incontinence. If urine doesn't escape, the patient is still healthy. There might be risk, but the patient is apparently healthy. Next test is Booney test, one of the most important tests. Booney test is applicable when incontinence of urine is due to descent of bladder or when there is weakness of sphincter. To perform this test, we need to place the patient in a comfortable position, either lithotomy or Sims position can be okay. And then both the finger, index and middle finger of dominant hand should be placed at the base of urethra. This part is the base of urethra. After that, we ask the patient to stress by coughing or by coughing normally. If there is, while you are inserting your finger and asking the patient to stress a little, if urine escapes, then there is incontinence. If urine doesn't escape, then patient is apparently healthy. Even if there is risk, patient now is apparently healthy. And what specifically we find here is either weakness of sphincter or weakness of neck of bladder. Neck of bladder is the tip of urethra. Remember anatomy. After this, we have a Q-tip test. We use a tip for this. Tip is a sterile applicator with a small piece of cotton at its tip. It is introduced to up to the bladder neck, and then patient is asked to apply stress. We have stress in every test because urinary incontinence is seen when there is stress to the pelvic floor muscles. That's why while diagnosing, we ask the patient to stress in order to determine whether there is involuntary passage of urine or not. So in Q-tip test, there is a cotton at the tip, at the Q-tip, and we introduce it to the bladder neck. And the patient is asked to apply stress. Angle between applicator and horizontal is measured. This is the angle which is to be measured. This is while the resting position, this is the tip, Q-tip. This is in resting position. And then we slowly raise it. We raise the tip and measure the angle. If the change in angle, change in the arc is more than 30 degree, that is abnormal descent of bladder neck. That means there is some problem in urine. There is problem like urinary incontinence because there is no support to bladder and support to urethra, muscular support. Increasing of the angle means there is lack of support or no support to bladder and urethra. Next test is cysto-urethroscopy. Oscopy means there is a device that is inserted to visualize some organ. Cysto-urethro is visualizing urinary system organs. Mainly bladder neck is examined. In cysto-urethroscopy, we see an image like this of the bladder and urethra. Next is measurement of pelvic floor muscle strength. How strong is the pelvic floor muscle can be measured. There might be difference, like adult might have a strong muscle than older people, older adult. Younger adult might have a strong pelvic floor muscle, but still among the adult or among any age, this test can be performed. And we can give scores. Score can range from 0 to 5. If there is no contraction of muscle, as I said previously, because of the contraction of muscle, any organ inside the pelvis is able to perform its function, is able to move. So 0 means there is no contraction, 5 means there is a strong contraction, strong squeeze with a lift. If the organ is able to contract, there is a slight lift. In between that, we have flicker contraction, weak squeezing, fair squeezing, and good squeezing. Now management, we have medical management, behavioral management, surgical management, and nursing management. Behavioral technique or behavioral management because passing urine is one of our daily behaviors. So we can psychologically manage the problem by using behavioral technique. Let's view medical management. We have following medicine with dosage and function: anticholinergics, cholinergics, mirabagrons, alpha blockers, and estrogen, topical estrogen. Anticholinergics can be used to treat overactive bladder, mirabagrons for urge, alpha blockers for in men especially who have overflow incontinence, and topical estrogen topically over the surface for menopausal women in the form of vaginal ring or cream. In behavioral management, we can provide training to the patient. We can first of all educate the patient about their condition, and we can counsel them that behavioral management is also important. First behavioral technique is bladder training. We can train our bladder to hold the urine for a little while. When the patient is having incontinence, we can actually train our bladder to hold the urine for a while. The main purpose of this bladder training is to lengthen the time between trips of toilet, between one toilet trip and another. If this training becomes successful, there can be a gap of 2.5 to 3.5 hours between one urinary trip and next urinary trip. Next behavioral management is double voiding. Urinating once, waiting for a few seconds, waiting for a while, urinating again, and then returning back. That is double voiding. Voiding 2 times so that we can lengthen the gap between two urinary cycles, two urinary trips. Next is scheduled toilet trips. If we make a timetable schedule for visiting the toilet, that can be also a nice neurological training, nice muscular training to our bladder. And according to this schedule, we should drink water. We should drink limited amount of water or water as per the prescription of doctor for the treatment sake. Otherwise, there is no prescription for water, no such thing as prescription for water. Next is fluid and diet management. After all those behavioral management, there can be also fluid and diet management. Some kind of food or some kind of fluid, it disturbs the acid-base balance of the body, or it disturbs the metabolism of the body because of the content inside that food. Food like caffeine, food like beverages, cold drinks, alcohol, or excess acidic foods. What they do is, they first of all disturbs our metabolism, they disturbs our caloric balance, and then they, in a long run, if we take such foods for a continuously long time, they might also create obesity. So fluid and diet management can be done. Along with that, if there is mild exercise on a daily basis, mild 5 to 10 minutes exercise on a daily basis for pelvic floor muscles, would be even better. Surgical management can be, first of all, surgical management cannot be just for urinary incontinence. It can be to treat the disease that is causing urinary incontinence. Disease like vaginal prolapse, uterine prolapse, cystocele, urethrosil can cause urinary incontinence, which can be treated surgically. First of all is urethroplasty, repairing the urinary organs, repairing the urethra. This can be done in cystocele, urethrosil. Urethropexy, establishing a bridge, a connection between pelvic floor muscles and urinary muscles, bladder muscle, urethra muscles, urethropexy. Suspension is again establishing a network between all the surrounding muscles, other organs, and the organs that we need to treat, urinary organs. That can also be done. Next is tension-free vaginal tape. This is the kind of tape which can be inserted from outside. We can surround the bladder actually along with the muscles by using this vaginal tape so that involuntary passage of urine can be controlled. This is the way we can insert the vaginal tape. After inserting by using a forceps, we can surround the organ that we want to control. Okay, we want to control urethra, bladder. Just surround the organ and it stays like this inside. So if we surround the neck of the bladder or if we surround urethra or bladder, we can actually control involuntary passage of urine by this surgical management. Finally, nursing management. In nursing management, first of all, we need to counsel and educate the patient about the disease condition. As this is more prevalent in women, counseling regarding menopause should be done. Women should be made sure that this is a natural process. Menopause as a whole is a natural process that occurs in every woman. And urinary incontinence is one of the symptoms of it that can be managed with time by using medicine, by using any kind of management, it can be managed. Next is pelvic floor exercise or Kegel exercise. Pelvic floor exercise helps in contraction and relaxation of pelvic floor muscles. One of the simple exercises, exercise during urination. Okay, while passing the urine, what women can do is hold the urine, count for 3 or 5, and then release the urine. Release for 2 to 3 seconds, again hold the urine. Count till 5 or wait till 5 seconds. Again release the urine. Practice this more than 10 times in every urinary episode. This can be practiced by postnatal mothers, mothers who are facing or women who are facing uterine prolapse and women who are facing urinary incontinence. By releasing the urine, what is occurring internally is contraction, relaxation of muscles continuously. Next can be maintenance of perineal hygiene. The whole perineum should be kept clean so that potential infection, risk of infection can be avoided. Next is health education. Health education should include topic which is overall related to urinary incontinence, like topic of pelvic prolapse, topic of cystourethrosil, topic regarding menopause, and that should focus on what is urinary incontinence, how does it occur in that disease. As this is not a medically treatable disease, only medically treatable or only surgically treatable disease, what patient needs the most is patient needs to understand what is the disease condition. Patient needs to have knowledge that what she is going through or what he is going through. And that is a nurse's responsibility. Nurses should convince them or educate them about their disease condition, about diet that they should follow, about habits that they should follow, and lifestyle modification. If their lifestyle has daily intake of alcohol, daily intake of caffeine, obesity, then there is a slight lifestyle modification that should be taken, like regular light exercise, avoidance of caffeine, avoidance of regular alcohol. Such management should be done. These were the nursing management required for urinary incontinence. Thank you so much. Next topic will be discussed in next video.